Well, there you are. Okay, hello. It's Sunday, June 30th, and we have a very interesting subject we're going to be talking about today. And frankly, we're going to be talking about it the next 2 or 3 weeks. And it's going to be under the title Economics of Medicine in the United States. And there's just, it's such an expansive area. It's a very large area. It's got to be of high concern to virtually everybody, let alone people in my generation, the boomer generation, who are getting up there in years. And we need to discuss it very frankly and try to keep the partisanship out of it as much as possible. Because no matter which side of the partisan debate you're on regarding medical care, I'm going to assume, for the purpose of our discussions, that if we can illustrate that money is being wasted, that it should be a concern, and that's going to be our approach in the next 2 to 3 weeks. By the time we get to the third week on this discussion, expansive discussion of medical care and medical treatment in America, we're gonna contrast our existing system, the one that we're going to spend discussing today and next week, with a Swiss system. And just to give you a heads up on it, the Swiss have a very unique system that I believe is decentralized, even though they call it national medicine. And our system, which I don't know, I don't really know what you want to call it. You want to call it Obamacare, go ahead. But it's a very centralized system. And that's going to be a very key aspect of the two systems that we're going to look at, particularly with respect to cost and efficiency and quality of medical care and the quality of the actual people delivering the medical care, which we're going to show some evidence has been in decline for some time now. So let's get going. It's Sunday right now, about 11:40 p.m. when we're recording this podcast, and let's get going. Let's start talking about medicine. So let's start out with what we're spending today, and I'm going to project one number, 2023. It's not going to be today, 2024, because we're not done with 2024 yet. So we're going to go back to 2023, and we're going to say that we're spending in America 4.9 trillion approximately on medical care. And we're going to also postulate that the government is 53% of that expense. In other words, the government is a little bit more than half. Now, the reason that comes up now is because later, when we contrast that with the Swiss system, we're going to see that even though it's called nationalized medicine and ours isn't, we're going to see that the government's contribution is significantly less. And I think it's important to remember that and not be mesmerized by the names of the different systems out there. So the other thing of note, we're going to spend a considerable amount of time on the course our medical treatment system has taken since the passage of Obamacare. Now, if you remember, back when Obama was proposing Obamacare, they had just nationalized the loan program for student loans, and Obama cleverly said before it was voted into action that we're going to pay for Obamacare from the interest on student loans. Well, fat chance that happened, right? I mean, now we're just giving away the principal too. So I would say that that was another total flop of an argument presented. So how significant is it to spend near 5 trillion a year? Well, let me tell you, in an economy that did 27.36 trillion last year, it comes to over 17%. It's a huge expense. It's over 5 times what we're paying on interest. It's over 5 times what we're paying for many things. Social Security, it's over 3.5 times what we're paying. And we'd like to think we're getting some bang for our buck out of it. The other thing that I think is noteworthy, and 1 second here while I fumble through some notes, is that in 2010, when Obamacare was passed, life expectancy averaged 78.7 years. And that was, if you wanted to break it up, was over 75 for males and 80.2 for women. Now, today, after 14 years of Obamacare, the other thing I want to mention before I get to the life expectancy, which you can imagine, it's not back to that level, is the jump up in social expense after Obamacare. We were spending roughly 12%, 12.5 to 13 at most of our GDP on medical treatment in 2010. After that, it jumped up to 17, 18% and has remained consistently there, with the exception of the COVID year, 2020, it hit over 19%. But with that one exception, it's remained 17 to 18%. It's the greatest percentage of any country in the world by a lot on medical treatment. And again, we're gonna look at it. In 2023, we spent $14,423 for every American citizen. That doesn't even count the illegals, for God's sake. And we're going to talk a little bit about that too. So longevity today has declined. For males, it's 78.4%. For women, it's 80.1. So it's not it's down, but not significantly down from what it was 14 years ago. So our lifespan hasn't grown. So how's our health? How's our everyday living? Our ability to move around? Well, that's gone down quite a bit. Today, I would estimate over 40%, 40% of the American population is in various stages of obesity. Now, why is that? I mean, we dramatically increased spending to the tune last year of about 1.4 trillion, as in trillion dollars a year, and we end up with a bunch of fat slobs in America. I mean, certainly obesity is correlated to everything that's not good. Certainly, it's a lot of weight on your heart. It reduces mobility. It reduces. It affects the brain. Obesity is not a good thing. So we've gone in 14 years. I think we could argue to a less healthy society than we had in 2010. And that's pretty significant. So we want to take a look at that too. And we're going to look at some specifics right now that are affecting medical health. And much of what we're going to look at through the prism of the historic relationship of a doctor and a patient, and then the today's relationship of a doctor, patient, and a third entity called the third party payer system. Now that payer system can be an insurance company, and we're going to talk about insurance because we don't think they're real insurance companies anymore. They have nothing to do with risk and pricing. Okay, so they're not insurance companies. We'll call them insurance companies, but the reality of it is they're not. Okay, so and the government payment system, the third party payer system, and the costs incurred to impose and manage those systems, and the effect they've had on individuals, not only on individual health, but also on their outlook toward costs and on their outlook toward their health coverage. So we're going to talk about those specifics, but before we do that, I want to say one other thing. There are various aspects of the government system of medical care. So it's a little deceptive uh, to isolate all the different government entities on the state and federal level that contribute to this huge spending on medical treatment. I mean, obviously, you have Medicare, okay, the old Medicare. You have a large aspect of Medicaid. Uh, you have, in addition to that, an awful lot of expenditures from the state level that are tied to Medicaid. You have, of course, the private health so-called insurance industry. Uh, and then you have other feed-ins to it. So when we come up, we add a number of things together to get to the 53% of the almost 5 trillion with a T a year we're spending on medical care. And our lifespans have not increased, they've gone down since the advent of Obamacare. Will Rogers made the comment years ago. He said, "You think medical care is expensive now? Well, wait till it's free." And that is profoundly true. And we're trying to present the picture that everything is scarce. And in a world of scarcity, when you take monies and they don't go to a highly efficient use, they're essentially you're depriving using that money on something else that could be a higher use. So let's get to it, and we're going to talk about the current system and some of the inefficiencies we occur, and we're going to get into that today. And when we finish it, there's going to be a very positive side of this next week, because we're going to get into the effect of AI, artificial intelligence, to reduce some of these expenses, but not all of them. But it's important you understand these expenses because they're having physical effects on our social system today after nearly 14 years of incurring them. So we're gonna go through a paper, actually a paper written back prior to Obamacare. And one of the areas I'm going to start with is what are the indirect costs that result from the administration of this third-party payer system. You notice, if you paid attention to our podcast, you notice a couple of podcasts ago, we talked about what is liberty. And we may even do a special podcast on July 4th about that again. But we differentiated between transfers of money, and which are coercion based, and transactions in which the participants feel better off. That's the condition that separates those two. So when you're in the third party payer world, you're in a world of transfers. Okay, they're not a world of transactions. It's not the typical the historic relationship where a doctor had a medical office, and he went to see your doctor, and they handled you handled the transact. The doctor said, "This is going to cost you, if you do this, $60. If you do that, it's $120." And you said, "Doc, I want the $60 and I only have 20." You did the monetary transaction in a minute. That's not the case today, but we're going to get to that too with direct costs. But right now we're going to do indirect costs. There is a loss of responsibility for payment of the service, and it changes the individual's behavior toward his health care in general and toward the physician who administered the treatment. He has an in other words, people, not only when people say they're covered, they have an expectation of coverage. but they don't understand the detail of it. So this is going to lead to eventual confusement. It's not the world where you're involved with a transaction with a physician. It's a third party payer and you don't understand the detail. But you have a relief from being dismissed of the responsibility of paying. I mean, you do have to incur transportation costs to go to a doctor's office and sit in a chair for God knows how long before you're called, a time cost, but you don't have a monetary expense. Or if you do, it's a limited deductible. So there's a big relief associated to that, and that relief has given people a false sense of their well-being, and I think it's directly led to the huge obesity problem we're suffering today. So in the United States, because of this sort of false sense of well-being defined by their medical coverage, but they don't know the detail of it. Okay, we know we have it, but we don't know the detail. And the concept, the notion that it's costless actually diminishes actions that are preventive. So, in other words, if you understand that you bear the consequence of your actions, you're not going to stuff as much food in your pie hole, maybe, and on and on and on. You're going to take a better care because you are liable for the consequences of your actions, and that's pretty true in everything in life. Uh, back to, I remember in college, we used to leave the light on and leave the room. And then some years later, I left the light on and got a utility bill. And I said, oh my God, I've got to pay this. And after that, I never left the light on. When I left the rooms, I turned the light off. Well, that's an efficient response to bearing the cost. But when you don't bear the cost, you don't actually behave the same way. Okay. And these are little subtle things, but they affect the whole picture. The separation of payment from the transaction of the service and the recipient, the patient receiving the service, it depersonalizes the doctor-patient relationship. In other words, when you're not paying the doctor directly and the doctor is dependent on a schedule to get paid, there are actually two subtle effects of that. Instead of the doctor paying attention to his duty on the Hippocratic Oath and looking at you as an individual, he knows where he's going to get paid because it's in a defined schedule. So there's a tendency of him overprescribing, and there's a tendency of him not paying enough attention to the particulars of your situation because the schedule is going to start dictating more of his treatment than you, the patient, which traditionally was the case. So the doctors are going to become schedule dependent, and the patients are going to get the false feeling that they're being as thorough as they were when they were paying attention to their individual needs. So both of those are going to translate into costs, health costs for the patient. So these are some of the these are some of the determinants. So if you take it a little bit further, you'll notice that doctors are becoming schedule dependent. And by schedule, I mean the coverages that are outlined by federal bureaucrats for Medicare, for treatment under Obamacare. They're going to be very schedule dependent, and they're going to respond to the schedule, and this is going to cause a cost. So let's just sum up 6 indirect costs imposed on medical care by third-party payer systems. The indirect costs. We're going to talk about direct costs too. Loss of responsibility of the patient for their health care. That occurs because they believe they're covered and they're not as attentive because they're not someone else is paying the bill, right? That has a subtle effect on people's behavior. The unrealistic expectation of infinite costless care by the patient, distorting the perceived value of care. So now what we're saying there is the concept of someone else paying has a fuzzy notion of what cost is and what is covered. So when patients go into that, they don't have the clarity because the schedules are horrendous. I mean, I've looked at them and I've spent time on them, which many people don't, and it's almost a horror story trying to understand what's covered and what isn't. And many people, when they think they're covered, aren't. Uh, the third thing is there's a distraction because the actual schedules, be they so-called insurance or government, we're going to talk about how government determines them even for insurance companies. The doctors are distracted by the third-party payer schedules as an absentee determinant of one that may vary from the particular diagnosis specific to the individual. So this, we mentioned this earlier, the schedule is dictating the treatment. Final four, distorted expectations and impersonal relations lead to increased litigation. Now, you've seen many ads of law firms advertising ambulance chasing doctors that are ambulance chasing lawyers that are looking for lawsuits against physicians. The number of lawsuits has increased against medical practitioners, as has the malpractice insurance the medical practitioners must pay. By some estimates, in 40 years, going back before 2010, malpractice insurance has gone up to 20 times what it cost. And that's becoming a more significant effect, a significant cost in the equation, particularly for doctors in private practice. Now, also, I might mention to you a couple of things. There's been a migration of doctors out of private practice and into hospital systems. Also, in the last 2 years, and these are the root causes of why we're talking about this. Last year, there were 80 hospital filings for bankruptcy. So far this year, a month and a half ago, a 33 hospital chain filed for bankruptcies. 12 hospitals closed their doors completely. So these are issues that we need to look at the primary causes of these things and examine them because they may even have an effect on boomers. I mean, boomers think, well, I'm covered, I've got Medicare, and everything's hunky-dory. We need to look at this very carefully and we need to understand it. So on number 5, for indirect costs, the patient's notion of free and costless care negatively influences, and we talked about it earlier, their prevention and their self-care is so suddenly changed. Hey, look, I'm watching my weight, but whoa, I look at that Krispy Kreme donut. Oh my God, I better eat one. One more won't hurt. Well, there are many things, even exercising in older age, becoming more computer dependent and cell phone dependent, that have diminished individuals taking care of their own health. And we go back to the statistics. I mean, if there were not 40% of this population was not obese a couple decades ago. And the big scurry to obesity drugs is an example of big pharma just going in to capitalize on a situation that pretty much is out of control for different reasons, for totally different reasons. And number 6, a patient's unrealistic expectation of costless medical coverage invites disappointments, depersonalizes the traditional doctor-patient relationship, resulting in loss of trust and, again, increased litigation. So, there's sort of a vicious cycle that we've gone into by allowing more of a government presence in our medical treatment, which has resulted in skyrocketing malpractice insurance, which has again diminished the care. So these are examples of indirect costs. So we're going to look at some direct costs next, of medical coverage, and I think, and I'm looking through my notes, and I think we ought to start this with understanding the basic transaction. Now, if you go back 40, 50 years, doctors took the Hippocratic Oath, right? They promised treatment and care. Now, of course, and one of the reasons for the arguments that medicine is an entitlement is that there are different levels of treatment and care, and the very wealthy can afford higher levels of treatment and care, and the poorer population cannot, if they can afford it at all. Well, historically, you had a doctor in an office, and if you presented yourself with a death-threatening condition, that doctor treated you. He didn't even ask. He didn't ask for anything. He treated you. And of course, later there might have been a bill and a discussion of repayment, and that was a process. Now, I might add, very many of the bills being incurred today in medicine, I think over 20% are not being paid. Okay, now much of that is doing to illegal immigrants who come in the system and primarily use emergency rooms to get medical treatment free, as they were instructed by the cartels. And one of those bills are not paid by anyone. But let's look at what the third-party payer system directly inflicted on the costs of medical care that really doesn't have anything to do with the actual treatment. Okay, well, let's start off and say a doctor sees a patient every 10 minutes, sees 6 patients an hour, 48 a day, 240 a week. Okay, well, now that nobody is paying in the office post-Obamacare, that means he must have a staff to fill out 240 applications for reimbursement so that he gets paid. Now, this staff didn't exist prior to the third-party payer system. Also, on the other side, there must be a staff, let's say in the government, or at a so-called insurance company, which it isn't really insurance because there's no pricing in accord with risk. So it's not insurance. They must have staffs of people to entertain each claim. And those staffs, when the claims are filled out in 1 month and sent away and received, the staff receiving it's going to make one of 3 decisions. One, they're going to pay the claim. 2, they're going to partially pay the claim. 3, they're going to reject the claim. Well, two of those decisions are going to cause that claimant to refile, more than likely, because they're either going to have to file with the insurance again and modify that claim to try to get something reimbursed, and they're going to at the same time send a bill to the customer, to the recipient of the service. So that process of that 10-minute visit takes over an hour. Okay, so you have staffs employed, bureaucratic stacks, and we're not talking about the regulators per se, because they've already passed these nonsensical regulations that set up this system uh, and impose this cost on everyone. You know, the system that was to be paid for by the interest generated from student loans. But today they're excusing the principles of student loans too. So so we need to understand that process and why it's causing a flight and abandonment of the traditional private practice into hospital chains, large conglomerates of doctors that go onto the payrolls of hospital chains. And then also how those chains are having monetary problems too. So the claimants uh, are filing claims. The doctors aren't being paid immediately, and the information of the claim may never be paid. Like I said, upwards of 20% are just not paid. They're incurred by the system. And that's where some of these hospital systems, particularly the ones that are privately owned, are filing for bankruptcy. They're not taking in the money to pay their bills. Okay, and that process is ongoing. It's unfolding right in front of us. The last 2 years has been somewhat horrific for the medical profession. Now, going back to the late 1990s, another thing I want to mention that's influenced greatly the quality of care. Uh, you had you had doctors. Uh, well, in 1966, you had the HIPAA Act, Insurance Portability and Accountability Act, and then you had COBRA passed later, and there were regulatory side effects to both of these. Now, I mean, don't get me. I sold insurance for a period of time, and I'm totally in support of medical privacy. Please don't think I'm not. However, there were secondary things imposed that started to effectively change the administration of medical services and get us into this third party system that became a nightmare for medical doctors and changed well in uh, there were two ongoing experiments at the time. Now we're back last century that were testaments to why it doesn't work. Yet both of them were copied federally. There was the California initiatives, uh, and there was a cost explosion in the Massachusetts plan for statewide coverage. Yet we didn't take any lessons from that, and we pretty much copied California and Massachusetts, and we have the same dysfunctional third-party system that they showed the nation last century doesn't work federally. And the tragedy of having that much regulation in the system is twofold too, because part of it limited the number of doctors uh, uh, and denied families to know about medical records. In other words, traditionally, uh, if you had so it was a violation to the sovereignty of a family, basically another violation by government by creating privacy prior to those efforts in privacy. I mean, it wasn't only limited to 18-year-olds. You might have a brother who's 40 or 50, and your physician would come to you and tell you what his medical condition was, and the family would get together and support that condition. They'd keep the costs internal. They wouldn't export them to the government. and the inefficiencies inherent in the administration of those costs. So basically, you had sort of a wedge driven into the traditional family unit by keeping medical records private, and it greatly increased the cost of administration back after HIPAA and COBRA were passed. Uh, so so basically all these elements have added to cost, and they've not even incrementally improved health. And I bring these things up today because, like I said, they're going to be our focus for the next couple of weeks. And we're going to come up with ideas, very specific ideas and solutions to address them. So we're not only focused on the negative, but and also we're going to try to get individuals more involved in their own health. Now, why do I say they're not involved? Well, I mean, when you see even children, elementary school children, blown up like blowfish on a dock uh, with calories, and you see the obesity running in people 30s and 40s and 50s, let alone 60s and 70s and 80s, the huge problem. You're creating your people are not taking that personal responsibility to watch what they put in their pie hole, frankly. And traditionally they did. I mean, I'll never forget when I was in high school back in the 60s. I mean, we had one sort of obese girl in a class of 367 in high school, and that poor girl, oh boy, did she take abuse for being fat. But every girl in high school was conscious of their weight and their health and what they put in their pie hole. Well, today they just throw everything in the kitchen sink down their mouth, and they look it, and their health is the same, and the repeat of adult diabetes has skyrocketed. All the secondary things, blood pressure, heart problems themselves, cancers, everything is more prevalent in conditions today than it was back in the 1960s. And it's due to individuals not taking care of themselves. Now, I know you want government to do everything, but government's not going to come in and change your diaper if you're 30 or 40 or 50 years old every day. And basically, there's a social expectation of unending entitlement. And we need to move part of that responsibility back to the individual if we want to enjoy health going forward. So, but as I said, when we finish these discussions in 2 or 3 weeks, we're going to be very specific, and we're going to recommend how we can correct this system because right now it's a mess. And I do believe no matter if there's going to be any survivability to America, which there's a lot of people that feel we're just going down the toilet. But if there's going to be any survivability going forward the next 2 or 3 years, the value of government spending and the benefit is going to be looked at very, very strictly in an environment where this year we're spending another 2 trillion, creating another 2 trillion of debt again. I mean, we went from George Washington through George Bush with 9 trillion of debt, and right now the last three, Obama, Trump, and Biden have created. At the end of this year, I expect 26.5 trillion. 3 presidents of money we don't have, money spent that we don't have. Now, if we don't get sober about that environment, and medical leading the list of expenses, if we don't get sober about that whole issue, we're going to go down the toilet, the whole system. So I'm assuming we're going to get sober, and there's going to be some realities that are going to come up next year, and we're going to start to pay attention to them. And that's why I'm conducting this investigation into medical care. And the other fact that's unacceptable is longevity, and frankly, uh, infant mortality rates. We're like 30th in the world, lose 560 newborns for every 10,000 people. We're we're not doing well for the not for spending any money. Even if we were spending it's not correlated at all to the amount of money we're spending. We're spending more than anybody else in the world, and you're going to see that when we look at the Swiss system. So I hope you'll stay with me on this. We're posting the paper that was written in 2008 that I've been talking from for the last 20 minutes on the website under consensus. We're going to distribute the podcast on this very important subject, economics of medical care, and we're going to spend the next 2 weeks on it. So I'm hoping we can get started. I don't mean to give you homework, but I would appreciate it if you read the paper on the website. Uh, and it will be a good basis for what's coming up. And by the end of the third week, I think we're gonna discuss a system that's would dramatically improve our medical system today. And we're going to discuss the benefit coming from artificial intelligence too, because that's not insignificant. It's already being used in certain aspects of the delivery of medical services. So I want you to have a blessed week. Again, remember your homework. Read the paper under consensus on odysseyin.info, odysseyin.info. Press consensus. Read the paper, The Economics of Medicine and Our Future Welfare, and be prepared for next week. We're going to talk more about these areas, and we're going to start to get to artificial intelligence and a system that's in existence right now that's going to make better sense than the one we have. So have a blessed week. I'm going to leave you now, and have a blessed 4th of July. We may come on with a 4th of July special to discuss our concept of economics of liberty, which I think is so important that people understand. And if not, have a blessed 4th of July, and we'll look forward to you next week. Tony, Chris, for Sunshine and Transparency is our program, and bidding you all farewell from the week, and looking forward to seeing you next week. Bye bye.